Okay, well, hello everyone. So I have the easy part of the session here. I'm just going to talk to you about all the good things that ADT does and all the ways in which it improves things in life, and Dr. Chi and Dr. Gunnar are going to have to go in with all the problems. So I'm going to just sing the praises. So the things we want to talk about are the use of ADT in these various settings, starting from early stage disease, intermediate and high risk localized, going to locally advanced, node positive, and then towards the end we'll talk about salvage after prostatectomy, and then a little bit about neoadjuvant before prostatectomy. So as you all know, the cure rates with radiation alone depend on the risk group of the patient. You start with low risk disease, you're getting a 90% cure rate. Intermediate risk, starting to drop off 75, high risk 60. By the time you get to node positive, less than 5% of these patients are going to be cured with radiation. And so it's no surprise that adding androgen deprivation therapy has been shown to improve overall survival in almost all of these settings, except for low-risk disease. And what we're going to talk about today are some of the trials that support this, and they're listed here, starting from the localized to the locally advanced to the node-positive setting. So those are the trials we're going to talk about in this first portion. And I think it's really important to know exactly when to use androgen deprivation therapy. As we've seen across the 90s, there was a very rapid increase in the use of ADT across all the risk groups. Even in the low risk group, if you look at low risk, it was 5.4% in around 1990. By the time it was 2000, you're looking at 57% of patients with low risk disease are getting androgen deprivation therapy. So let's start first with short course ADT, 4 to 6 months for intermediate and high risk localized prostate cancer. So we're just talking about the T2 disease here. Basically, 3 trials support this. The first one that was published was the Dana-Farber trial. This was published first in JAMA in 2004 and then updated in 2008. These patients were mostly intermediate and high risk. They went up to T2B, and you had to have either Gleason 7 or PSA greater than 10 or endorectal coil MRI evidence of T3 disease. 206 patients were randomized to 70 gray with or without 6 months of androgen deprivation therapy. And this trial showed at 8 years an overall survival advantage of 74% versus 61% favoring the ADT arm. The next trial, very similar, the RTOG trial, 9408. This had some low-risk patients, but again, it was mostly intermediate and high-risk patients. They went up to T2B, and the cutoff here for the PSA was 20. There were almost 2,000 patients, and they were radiated to a slightly lower dose of 66 gray and randomized to with or without 4 months of ADT. So instead of 6, just got 4. There was a 10-year overall survival advantage, 62% versus 57% favoring the ADT arm. So the magnitude of the difference wasn't quite as big. So you might wonder, these trials looked at both intermediate and high-risk patients. So what happens if we just look at the intermediate-risk patients? Do they also benefit? So if you look at this subgroup analysis of the Dana-Farber trial, the answer is yes. If you've got intermediate-risk disease, you can still get a survival benefit from a short course of ADT. This is the patients who got ADT, these are the patients who did not get ADT, and this is overall survival. If you look at high risk, there's an even bigger benefit. So you see the magnitude of the difference is bigger as the risk got higher with 6 months of ADT. The RTOG did the same thing with their trial, looking at the 4 months of ADT. And interestingly, what they found was only the intermediate risk group benefited. So again, low risk didn't benefit, that's fine. We knew that low risk prostate cancer didn't need ADT. Intermediate risk benefited, that was great. I think we all, we expected that. But interestingly, the high risk did not benefit from 4 months of ADT. I think there's 2 reasons for this. One of them could be that 4 months just isn't enough if you've got high risk disease. I think there actually could be a difference between 4 months and 6 months. The other possibility is you can see the curve separate a little bit, and maybe it was just underpowered to detect a difference in the high risk group. But going back to the idea that 4 months might not be enough for high-risk disease, what supports that is the third trial, the Denham trial. This is the TROG trial published in Lancet. And this looked at intermediate and high-risk patients and some locally advanced patients, 818 patients, randomized them to a dose of 66 gray, which again is a lower dose than we commonly used. And they could have gotten either 0 months, 3 months, or 6 months of ADT. And what they found was that 6 months improved overall survival, just like was seen in the Dana-Farber trial and in the RTOG trial. But 3 months was not significantly different in terms of overall survival. The hazard ratio was 0.84, the p-value wasn't quite significant. So I think this gives more evidence that 3 to 4 months may not be enough for high-risk disease. So one thing you notice that I kept mentioning that the doses were a little bit lower than what we currently use. And so the question comes up, if you used a radiation dose like what we currently use, instead of 66 to 70 gray, but instead 75 to 79 gray, do you still need the hormones? do you still need the hormones to make up, for if you're using a higher dose of radiation? And that's exactly what the RTOG 0815 is testing. They're going to give patients 79.2 gray of radiation, a high dose, and then randomize them to 0 months versus 6 months and see whether there's still a benefit. In my feeling, I think there probably will still be a benefit. I think that the benefit of ADT for these patients is actually to destroy some micrometastatic disease, but we'll see when the trial is published. Okay, so let's go on to long course ADT now, 2 to 3 years for patients with high risk or locally advanced disease. So you got localized disease, you're going to give 4 to 6 months. High risk or locally advanced disease, you're really looking at 2 to 3 years. And the two studies that support that are the RTOG study and the BOLA study. So RTOG 9202, published in 2008, looked at patients with T2C to T4 disease with a really high PSA cutoff of up to 150. And 55% of these patients had T3, T4 disease. So we're really talking about locally advanced disease here. It's not just kind of your standard localized disease. Large trial, 1,500 patients, 65 to 70 gray with either 4 months or 28 months of ADT. What this trial found was that 28 months improved the 10-year prostate cancer-specific mortality. It was dropped from 89% to 84, went from 84% up to 89% significantly. And overall survival was not improved in the overall trial, but when they did a subgroup analysis, just looking at the patients with Gleason 8 to 10, there was a significant benefit in overall survival. So this kind of proved the concept that long course ADT is better than short course ADT when you've got locally advanced T3, T4 disease. And that was shown again in the EORTC trial. This had 77% of the patients with T3 or T4 disease, and actually 6% of the patients had node-positive disease. So these are pretty locally advanced patients. Almost 1,000 patients were randomized to 70 gray with either 6 months or 36 months of ADT. So again, going with short course versus long course. And 36 months reduced 5-year overall mortality by 3.8%. So basically, you've got two studies now showing a survival benefit with the longer course hormones. And so based on these trials, I would say that 28 to 36 months really should be considered the current standard for patients with sort of very high risk to locally advanced prostate cancer. But if you've been at this meeting or kind of read the newspapers from Orlando in February, you've heard something about 18 months. And what should we do about 18 months? And in fact, on this stage, just a few hours ago, was presented some of the data on 18 months. And in the whole prostate cancer landscape, 18 months really is sort of the new kid on the block. And there have been two ways from which 18 months has sort of come on the scene. One is from the 6 months direction. The TROG folks are looking at 6 months versus 18 months and trying to see whether they can improve upon 6 months by going to 18 months. And this trial is going to report its survival differences in about a year. On the other side, the Canadians did the PCS4 trial, which compared 18 months and 36 months. So trying to see if you can come down from 36 months to 18 months and seeing whether you'd lose anything. So let's talk about that data because that's what's gotten all the press and that was shown today. This was first released at ASCO GU back in February. And this was 630 patients with high risk and locally advanced prostate cancer. The inclusion criteria was either you had to have T3, T4 disease, and 25% of the patients had that, or PSA greater than 20, that was 44% of the patients, or Gleason 8 to 10 disease, that was 40% of the patients. So these are pretty high risk patients. They randomized them to 70 gray with either 18 months or 36 months of ADT, and the median follow-up was 77 months. And basically, there was a trend, but certainly no statistically significant difference in biochemical failure. The rate was 25% versus 19.4%. And there was no significant difference in overall survival. The hazard ratio was 1.15, the p-value was 0.398. So a lot of press came out at the time saying, well, there's no difference between 18 and 36 months, we can just use 18 months now. Let's take a look at the curves. So this is overall survival in the PCS4 trial. The blue line is the 36-month patients, and the orange line is the 18-month patients. And although the p-value sort of fell off here, actually when they looked at the 5-year time point, there was a near statistically significant difference between 92.1% and 86.8 with a p-value of like 0.059, although the curves wound up coming together with more follow-up. So what can we conclude from this? I mean, would you say that 18 months is a new standard? I don't think we can say that yet. The PCS4 trial was really not powered as an equivalent study, which is a pretty high standard. To be able to say two things are equivalent, you need a lot of patients. Or a non-inferiority study, which still needs a lot of patients. So you can't really say that 18 months has been proven to be either equivalent or non-inferior to the standard of 36 months. And let's look a little bit more closely at the hazard ratio. So the hazard ratio for overall survival is 1.15, with this 95% confidence interval going up to 1.59. And so what can you conclude from this? It wasn't statistically significant, but if you were a betting person and you had to tell your patient what you think of this data, it might be reasonable to say that you would guess that 18 months probably results in about a 15% relative increase in deaths. And statistically speaking, we're not sure. It could be up to a 59% increase in death because that's the upper limit of the confidence interval. And so because of that, we definitely can't say that it's a new standard yet, in my view. But I do think that the data can be used to individualize treatment. You know, we're not just going to close our eyes and say we don't know what's going on with this trial. You know, we have to incorporate the data and say, look, are we willing to accept perhaps up to a 15% relative increase in deaths, or even a higher, up to perhaps 59%, which is unlikely. But if you're looking at the patient in front of you, you can sort of individualize therapy because you've got to trade that off against the decrements in quality of life that are going to happen by staying on longer hormone therapy. And what further work is going to be needed to be done is to try to figure out which patients really need to go all the way up to 36 months and which patients can just stop at 18 months. It can't be that everybody's going to benefit from going all the way to 36 months. There must be a subgroup of patients where it matters. It might be the younger patients, the patients who rebound their testosterone sooner, but we'll have to see. And really further follow-up is needed with this to try to narrow this confidence interval. The confidence interval is so wide right now, we really need to get more narrow before we can be totally confident about it. But I think this is still very important data and we can still use it in the clinic. Okay, let's talk about lifelong ADT for node-positive disease. Two trials. One is the RTOG 8531. This was published in 2005 in the Red Journal, and basically looked at either T3, T4, or node-positive patients. And 28% of the patients were node-positive. So this is a pretty special, unique population we don't really see a lot. But ADT improved 10-year overall survival in this trial significantly. And on a post-hoc analysis, just limited to the node-positive patients, you're just looking at the node-positive patients now, ADT also seemed to improve overall survival. And this was lifelong ADT. The other trial, which you all know about, is the ECOG study. This was after surgery. It was published in the New England Journal. So for node-positive patients after surgery, they were randomized to either observation or lifelong ADT. And ADT significantly reduced all-cause mortality with the relative risk shown there. And so just before moving on to the last two things, I just wanted to summarize where we are with the ADT durations. I think there's a pretty clean story here. Basically, if you read the standard, as you get more and more aggressive on the scale of how aggressive the prostate cancer is, you need to lengthen the amount of hormone therapy you give, starting with 4 months to maybe 6 months for intermediate risk prostate cancer. Once you get to high risk, you can treat some of these men with 6 months, the more favorable ones, but as you get to unfavorable high risk localized, you really need to go 28 to 36. And node positive, we're looking at lifelong. But there are still questions. Can we use 18 for some of these high risk or locally advanced patients? That'll really depend on longer term follow-up of the PCS4 study and then what the results of the TROG study show next year. And for node positive patients, even though the two trials I showed you used lifelong hormone therapy, I think in practice people are starting to peel back a little bit, maybe using a little bit more of 2 to 3 years. There's no evidence one way or another to use it, to stop at 2 to 3 years, but it's something that some people are doing. So we'll have to see about that. There's no trials looking at that right now. Last two things I want to talk about. One is using ADT with salvage radiation. So these are patients that had a prostatectomy and now their PSA is rising. The trial that basically supports this is the RTOG 9601 trial. This was presented at ASTRO in 2010 and then again at the ASCO GU meeting in 2011. This was 771 men with either pathologic T3 disease or margin positive disease, and they had a rising PSA after prostatectomy. They got salvage radiation with or without 2 years of bicalutamide, 150 milligrams, which is not something that we use in the United States. And the median follow-up was 7.1 years. And what they found was that bicalutamide reduced the risk of metastases at 7 years from 12.6% down to 7.4%, so an absolute benefit of 5%. And very interestingly, this tracked the overall survival difference, which was 91% in the bicalutamide arm and 86% in the no bicalutamide arm. But there were too few events to test the statistical significance of this. So we definitely cannot say this is statistically significant. It has not yet been tested or reported with a p-value. But it's interesting that it sort of tracked the difference. The question that comes up now in practice is, how are we going to use this data? Are we going to give everyone 2 years of ADT in the salvage radiation setting? The Radicals trial in the UK is actually testing 0 versus 6 versus 24 months of ADT. And so, we're going to get some information from that when that's published. And the RTOG itself has actually moved a little bit more towards shorter course in this setting. The RTOG 0534 is testing 0 versus 4 to 6 months of ADT with salvage radiation. And so, even though the 9601 used 2 years, we're seeing studies looking at 6 months. And we'll get the reports of those, I'm sure, in the future. Last thing I want to talk about is the concept of neoadjuvant ADT before prostatectomy. Should we be giving patients a little shot of Lupron before they go into their prostatectomy? As you know, there have been multiple trials looking at this, especially looking at 3 months of hormones before prostatectomy. And there was a recent meta-analysis done looking at 8 of the trials giving 3 months of ADT before prostatectomy. And what was found was basically this 3 months of ADT would reduce the positive margin rate, cut it in half, in fact, with a relative risk of 0.49. And it increased the chance of having organ-confined disease, relative risk of 1.63, but there was no benefit in the things that we might really care about, like disease-free survival, disease-specific survival, or overall survival, where basically it was totally a wash. And so why is it that neoadjuvant hormones didn't impact outcome before prostatectomy? Sorry, before prostatectomy. Whereas with radiation, it's such a part of the standard of care. And I think the answer is probably 2 months is just 3 months is too short a duration. 3 months has no benefit in the radiation literature either, as you've seen. So I just don't think it's enough. And the other thing you've got to consider is that if 3 months doesn't benefit radiation patients, it's very unlikely to benefit surgical patients, because surgical patients tend to be younger, maybe 8, maybe 10 years younger than radiation patients. And if you give a 65-year-old gentleman 3 months of hormones, his testosterone is going to bounce right back up in about 3 months. Whereas when you give a 73, 74-year-old patient who's getting radiation 6 months of hormones, that can often turn into 2 years of androgen suppression. But that doesn't necessarily mean that we should close the door on the possibility of giving hormones before surgery. And I think there's a lot of interest in these sort of next generation neoadjuvant ADTs. And a lot of excitement came last year here at ASCO when Dr. Taplin presented her randomized phase 2 pre-prostatectomy study looking at 58 men with high-risk prostate cancer. And all of them got some amount of abiraterone. So it was 3 months of GnRH alone, plus 3 months of GnRH with abiraterone, or 6 months of GnRH and abiraterone. So all of them got some kind of abiraterone up front. And very interestingly, 4% versus 10% achieved a pathologic CR. I mean, that's something that we just weren't seeing with just neoadjuvant GnRH agonists alone. So that was a big deal. And then 15 versus 34% achieved a path near CR. We still don't know what the long-term result is. Is this going to translate into a benefit in disease-free survival, metastasis-free survival, overall survival? It may. It's an exciting concept. We'll have to see. I think we're going to be seeing a lot more of these kinds of studies down the line. So I'd say don't close the door yet on the possibility that ADT could be used with surgery. And I think with that, I'm going to turn it back over to my colleagues. Thank you for listening.